Hello, my name is Christine. Thank you for attending this presentation on proton therapy treatment planning and practice. Now, as a caveat, every institution and planner is different, and even planners within the same institution will not always have the same method. So outside of these factors, approaches can vary even further depending on a multitude of other factors, including treatment site, concurrent or previous treatments, and the physicist and physician assigned to each case. This presentation will try to give a general approach with some specifics sprinkled in that I use in treatment planning. I tried to curate different approaches that I learned over the years from the amazing team at the MD Anderson's Proton Therapy Center, though nothing I present here can be used to reflect on every decimetrist that's there. This outline is a generalization of the steps we go through from start to finish per proton plan, not including the follow-up steps such as verification and adaptive plans. I will also not include complicated cases such as those with combo plans with photons or cases with previous treatments, as those could be their own hour-long presentations. So just to start off, we have importing, pre-plan review, contouring, plan setup, optimization/planning, evaluation, and then a summary. All right, so let's start with importing. And depending on your institution, step one should typically be exporting the scans from your packs. For protons, it is important to mimic the treatment conditions as close as possible, such as removing or replacing the simulation couch. Next, you should import the scan into your treatment planning system along with any relevant images or scans that will be needed for contour assistance, such as MRIs or PET scans. If applicable, this is also when we import, deform, and register any previous radiation treatment dose. Okay, so the pre-plan review will save you a lot of time further down the line. It is better to address any issues up front rather than having to replan a patient and cause treatment delays. It is important to make sure the scan and patient setup are compatible for proton planning. Okay, so we make sure to review the CT properties, such as looking to make sure it's not the extended Hounsfield unit scans and that it's not the extended field of view scans. The issue with the extended Hounsfield unit scans is it can cause very poor low contrast resolution since the CT number jumps every 10 Hounsfield unit, making it unsuitable for proton planning. And similarly, the Hounsfield units are unreliable near the edges of the scan. So when you reconstruct an extended field of view scan, it also makes it unsuitable for proton planning. And in these cases, we will need the original scans or to resim the patient if they're not available. With protons, we don't want too much guesswork when it comes to what is in the beam path, such as what you're doing when you're having to manually contour and override too much metal, tissue, bone, etc. manually to set the Hounsfield unit. You're basically drawing the patient at that point, right? In addition, we cannot treat through metal, so you have to consider which beams may be used and whether or not there's enough space to treat around it using planning targets to avoid that metal. In these cases, I would speak with physics and the physician on the best course of action per patient. Most of the time, there are acceptable workarounds to allow for safe proton planning, although once in a while, it is recommended that a complex patient be treated with photons instead. We also review for things such as device or patient cutoff within the treatment area. Most things can be mitigated, but it's important to thoroughly review everything to make sure that it's all accounted for way before you start planning. So for example, this is a prostate patient, which we treat with laterals to avoid treating through the bowel or rectum. The laterals in this case would go straight through the missing parts of the backlog. The solution for this case, per discussion with the entire team, meaning the therapist, the decimetrist, the physicist, and the physician, was to resim the patient on a CT with a larger bore size and add 3 millimeter distal margin to the lateral beams. Because remember, protons travel a certain distance prior to losing all of their energy. So if there is more material in the way than the treatment planning system can see on the CT, the beams will stop short and undertreat the patient. We also decided to increase the perturbations from 3% to 4% to further accommodate any uncertainties. And you can see from the first image that it looks like the backlog may only be missing a little bit of material, maybe following this kind of pattern. But you can see on the second image that there was actually quite a bit of backlog that was not included. So you do have to be very careful for these cases. In contrast, for this liver case, it had less vac lock cut off, and it was pretty obvious. Physics decided that I draw in a small triangle to estimate the missing backlock and set the Hounsfield unit to the average of the area, which was about 950. And so reproducibility of setup is important in general for radiation treatment planning, but arguably it's even more important for proton therapy. So for example, this prostate and lymph node patient has a lot of stool in their rectum, which is probably not reproducible day to day. We don't normally treat the prostate area with the PA beam, but it was important to create an expansion on the rectum to crop it out of the PA field to make sure that we completely avoid treating through the stool. We also did a verification plan prior to treatment by contouring the stool and overriding its water as a worst case scenario. Other issues could be air pockets in the vac lock, strained folds in the neck, or maybe tissue interfaces that look a little bit strange, such as this example. It's very important to have a conversation with the entire team and include everyone on it as far as to figure out the best way to proceed per patient. In this particular case, the therapists were very sure that the setup was reproducible to an acceptable degree, and so this patient was treated like this. So, on to contouring. After reviewing the CT, you send it back to the physician to complete their contours. The symmetrist will contour the body, any overrides, necessary organs that the physician didn't contour, and all the planning structures. The body contour is very important for proton plants, particularly in Eclipse, since it serves as the dose grid size. In Pinnacle, if something is not included within the dose grid, it will still calculate it, but it won't show it. However, in Eclipse, if it's not within the body, it just completely ignores it and treats it as air. So we have to make sure that everything that may come in the path of the beam during treatment is included within the body, such as the treatment devices. And similarly, anything that will not be present during treatment, like the blankets, should be removed from the body contour. And it's also important not to include any artifact that's not real as well. So overrides are similarly very important in proton planning. Protons are more exact than photons due to the pristine Bragg peak. So we have to make sure that the treatment planning system is able to accurately account for anything in the beam path. As I'm sure you know, CT values above 2500 are less accurate due to the metal artifacts caused by the high density implants. So we have to make sure to contour and override these to the more accurate values. Most metals have an understood range of Hounsfield units, so I believe individual departments may have different acceptable values to override specific metals to. As you can see from this example, sometimes you may need to override multiple metals. In this case, the dental screws were overridden to titanium, and the dental fillings were overridden to silver. In addition, we had to override the air, the stent, and tissue all separately. Sometimes, to find out what the exact material was used in a patient, you have to do a little bit of research. You can look through their chart or speak with the physician who can get in contact with the surgeon who performed the surgery. In addition, you may need to contour and override gas in the bowel and rectum and override that to water. So everyone does planning structures differently, but I will give some examples of some that I like to use. It's important to create enough expansions on serial organs in order to mitigate any uncertainties in the calculations to accurately prevent patient harm. And these can be dependent on the institution. However, we do tend to use 3 millimeters for expansions on cases that use a mask and 5 millimeters for expansions that do not. So even in this patient that's all in the head and neck mask, we use 5 millimeters for the spinal cord, and we use 3 millimeters for the brainstem. And here are some examples of some planning structures that I like to use and find helpful. I use contours that I call overlap contours to help control hotspots within or near the OARs that are close to the target. I tend to use a 5 millimeter expansion of that OAR and get the overlap of that with the 5 millimeter expansion of the target. And then I set a max dose objective to that. And you can can see this here for the sigmoid. I also use avoid contours. These help push the dose away from the OARs, further away from the target, so that you don't create a conflicting objective with it. Similarly, I use a 5 millimeter expansion of the OAR. However, this time I crop it 10 millimeters away from the target and set a GEUD objective. And so you can see here, this here would be able to be pushed a lot harder than anything closer to the target. Right. I also use what I call upper contours for multiple dose levels to push dose off of the lower dose levels. I crop a certain percentage away from them, and you can see the upper contours are in bold here, here, and here, and they're just cropped a certain distance away from the higher levels. And these will allow you to really push that max dose on them individually. So sometimes you may need planning targets to help with robust optimization. For example, the optimizer may attempt to drive dose into the airway to increase robustness to it, which you don't really need. And in these cases, I place a non-robust min dose objective on the original target, so the full target here, and then I do a robust min dose objective on just the planning target. And so this will be optimized robustly, and this one will also get dose, but it won't be robust. You may also need the planning target contours to be cropped away from serial organs, such as the brachial plexus. You can see the CTV 56 on the right side does not need any cropping because the max dose constraint is 66 gray. The same goes on the left side. The CTV 62 does not need to be cropped. However, the CTV 66 will need to be in order to meet that constraint. In these cases, I put the target objective on the planning CTV. So this will be robustly optimized to 66. And this one, similar to before, will not have a robust constraint, but it will have one, but it'll just be a couple gray lower, maybe 2 gray, just so that you can still meet this max dose. Okay, so now that the contours are all ready, it's time to get started with the plan setup. So let's start with beam angles. In contrast to VMAT, IMPT depends heavily on beam arrangements. Some institutions may have standard beam arrangements for certain sites. However, some general rules still apply. With protons, there are a lot of limitations on beam placement, so sometimes it's best to figure out all of the places you can't put beams before you can figure out the optimal beam angles. So common things to avoid include metal, gas, ranging into serial organs due to distal range uncertainty, treatment device corners. This is just in case there is setup variation. We don't want to plan for a couch to be in the beam path that is sometimes there and sometimes not, and vice versa. We also try and avoid beams that go parallel to treatment devices. Similar concept, this is just in case there is setup variation. We don't want an entire cross section to be unaccounted for if there is small variations in setup. If you are going in parallel to this, you could completely miss out on this. If you go off just a little bit from this, you would only be missing this much of the setup devices. We also try to generally avoid beams parallel to each other to reduce uncertainties as well. What we do try for after we have limited our options is for en-face beams and to spread them out as much as possible. And for thoracic cases, I look for at least one off-chord beam. All right, so here's an example of all of this in practice. The blue line is the proximal margin and the orange line is the distal margin. I worked with physics on this case to find the best beam angles. We opted for 4 of them to spread out the dose and uncertainties. Beams were picked to avoid ranging into the brainstem, so as you can see, none of them are ranging into it. The third beam had to clear the curve of the board, and there was some discussion about how it's kind of parallel to this ear canal. However, it was the best one to avoid ranging into the brainstem at this angle. So we went with it and we evaluated the effect of it using uncertainty analysis, and it was fine. And this second beam here was intentionally off by 5 degrees from being parallel from this third beam. This vertex here was used to carve the dose away from the brainstem a little bit better. Beam-specific targets are pretty common for complex proton plans. These help prevent treating through or placing spots in undesirable areas, such as within metal or the OARs. It's important to crop along the path of the beam, so you do have to view this through the BEV as you're doing it. And it's also important that while you're doing it, you're making sure to use the appropriate margins in the crop, such as 3 millimeters for the dental filling. So you can see in this example, that's exactly what I did. And you can tell from this coronal view, it is going along the path of the beam. You can also see in the BEV, it's perfectly kind of carved out there. And in this case, I cropped the brain out of the PA field. And so you can see the actual target goes up pretty high, but we don't need the PA treating the brain field. We can throw on some more anterior beams for that. And so I just cropped the brain out of that. And this one, I cropped 3 millimeters away from the eye and 10 millimeters away from the lens. You can see here that it's parallel. It's also important not to unnecessarily treat through normal tissue. So this is another use for beam-specific targets. So you can always crop away the disjointed contralateral target, which you can see here. The left side is completely cropped out of the right side target and vice versa. You have to be very mindful of the distal end of the beam in these cases because sometimes it's necessary to treat through the normal tissue in order not to range into a serial-like organ such as a sigmoid. In a similar situation here, you don't want to cut this in half right here and then have all of the uncertainties just in this area. So we just keep all of this intact if the actual target's intact. All right, so now you've done all of the prep work. You've imported the plan and addressed all possible issues prior to starting the rest of the process. You've completed contours, including preliminary planning structures and choosing your beam angles and creating robust targets. You've set up the plan as well for your institutional standards, which I haven't included in this presentation since these steps are going to be so much more specific to your department, such as ISOs or user origin placement, checking for beam clearance, choosing treatment machines, snout position and snout size if applicable, adding necessary energy absorbers if the target is too close to the surface, utilizing naming conventions, inputting prescriptions, selecting correct calculation models, and setting up those parameters, such as spot spacing. There's just a lot of things that may be very specific to your institution, so I didn't want to cover those, but we can move on to optimization now. Okay, so in order for the optimizer to account for the uncertainties, you need to first add them into it. These are called perturbations in Eclipse, and you just click on Edit Perturbations, and it pops up this window. The 3.5% is the CT uncertainty. In this particular case, I used 0.2 centimeters for the setup uncertainty, but I did use 3 millimeter uncertainty when I assessed the quality of the plan. But this just helps with the optimization. And this is something that I always discuss with physics. Before I get into the optimization, I ask them to review and approve the beam angles, beam specific targets, and the perturbations that I plan to use. This is always good to stop here and have a good discussion to make sure that what you're doing is what they want, right? So at minimum, you should be accounting for the CT uncertainty. Sometimes also including the setup uncertainty creates over robust plans and the dose is kind of everywhere. So if possible, also account for setup uncertainties. After setting the perturbations, you just have to set the targets and serial-like organs to robust objective, which you can see by the check mark in Eclipse. And as far as building the rest of the objectives, a good place to start is referencing the physician's planning directive for that particular case. And here, as an example, you can see that I have the robust objective on the spinal cord itself with a lower max dose objective and an additional objective on the 5 mm PRV that is not robust, but this one's being used to make sure this 45 gray is met as well. And another example, the brachial plexus in this case were overlapping or near to different targets. So right side has a lower constraint than the left side. And so I just set these a couple centigrade lower so that it'll meet it for sure. Okay, so for me, I always do the first run only with the targets on. This gives me time to evaluate if there are issues with the targets or the beam-specific targets themselves. Sometimes this can even indicate if there is an issue with the patient setup. This gives me a good idea of what kind of coverage is achievable since nothing's really being pushed. The second run, I start to build the objectives on the higher priority constraints, such as the spinal cord or the brainstem. Since these constraints must be met, this will give me time to evaluate if the targets need to be adjusted to meet them, such as cropping the PCTVs further away from them. And the third run and on, I start adding objectives and slowly pushing them until the target coverage is lost, which is usually when you know you've gone too far. It's important in this step to keep an eye on the cost of the objectives. This will give you an idea if there are any conflicting or unreasonable objectives. Many optimizers will quit early on without fully optimizing the plan when it runs into the situation, so you wind up with a not fully optimized plan. And during these steps, I create any planning contours as necessary, such as spot contours, shaping contours, or hotspot contours, which have their own uses. For the shaper contour, this is an example of one that I've used in the past, so you can see what I use it for. This dose ended up being pushed superiorly into the airway because of pushing on the carotids. And to get rid of this, I just put a max dose on a contour in the area and I pushed it down, and you can see I got rid of most of it. And in the same case, but a little bit lower down and the same shaper, I used it to separate the targets a little bit better. You can see here from this magenta line that it's now separated in this plan. Okay, make sure that you are gradually pushing objectives. I start with a reasonable objective based on the initial runs when I was just doing targets, and that incrementally either decrease the OAR objectives or increase their priorities to better meet them. For example, I start mean dose objectives around 2 gray less than the actual dose and keep lowering that to make sure that it stays 2 gray lower the entire time. In my experience, planning in protons isn't necessarily something you can just kind of set and forget. You have to continually watch the cost to make sure nothing's being pushed too hard or harder than the targets. And you have to continually adjust the objective to gradually push the plan. Sometimes I notice the plan will break if I go straight to a lower objective that I know it can meet, but it just breaks the plan instead. So if I slowly bring the objective there, it gets there over time. Next, you should watch the optimizer and wait until it meets the current objectives before pushing more. So while the optimizer is working really hard, it's going up here. These bars are really long. You don't want to do anything there. It's working, it's doing its thing. And then whenever it comes back down here, this is when you can go through your objective list and start pushing more as necessary. Also, what I do is make sure to keep each run. I copy and paste each plan prior to further optimization so that I can go back, and if something goes wrong, and it gives you a reference as well to compare to. For example, I mark each plan that looks okay to me. And then at the end, when I think I've managed, a really great plan, I'll compare all of the ones I thought looked okay before. And sometimes I'm surprised that in the process to get what I thought was a better plan, I missed something along the way and I have to go back to an earlier trial. So it's great when they're still there. Some important things to keep in mind. There is a lot of trial and error for each case. No two patient is the same, and and therefore no two exact methods will work foolproof. I always have to change something a little bit for each patient. Always, always stop and evaluate if something is wrong. In clinic, one of the worst things is wasted time. If you waste your time going down the wrong path, it can cost you days in the treatment planning process and cause possible patient delays as well. Keep an eye out for red flags, like this one. If you see that the optimizer is really working hard on something, that could be a typo, it could be a wrong contour, it could be anything. Just investigate and see what's going on. Don't just keep going with it. And also, try to keep objectives simple. It's surprisingly very easy to confuse yourself and the optimizer, and you don't want either to be confused on the objective of the plan. Okay, so now that optimization's done, you think you have a great plan. Now it's time for the evaluation of the plan's quality. In general, this review process is pretty similar to photon planning. You have to make sure that all the OER constraints are met, target coverage is met. You check the targets for homogeneity. You check for the plan's hotspots and their placement of the hotspots, conformality of the dose. But what's not similar is that we have to further evaluate for robustness and spot placement. So I'll go over these steps. Okay, so the first step in the robustness setup is to set the plan uncertainty parameters for it to calculate. And so here you can see again the 3 mm setup uncertainty for this, I believe, a head and neck case, and then the 3.5% CT uncertainty, which is for all cases. Okay, and so something to keep in mind when you're reviewing the robustness on the DVH is that the bands may be wide, but it's important to note that these variations are spread out daily throughout the treatment. And so the average should still be somewhere around where your plan is. However, if you do see something that's concerning to you, you can go to the plan itself and review the specific plan that may be causing problems. In this case, prior to doing this step, the spinal cord was receiving greater than 45 gray Dmax in a 3 mm shift in the Y direction. So I went back to the plan, which you do by first reviewing which uncertainty it is, and then finding that uncertainty in the list, right click, drop to view. So I did this, I went back to the plan and reviewed that. So I scrolled to where the max dose was and manually spot contoured the area and placed a max dose to push the 45 gray line further away, resulting in the 44 gray Dmax. And keep in mind, physics will do their own checks, particularly for spots. This is just part of the Swiss cheese model to make sure that nothing's missed. So for example, I like to check on the initial run if there are any spots within the dental fillings. I scroll through all of the layers of spots to see if there is any overlap. And as you can see, the spots nicely go around the dental fillings in this case. I would crop further away on the bean specific targets from the dental fillings if needed. Okay, so at the end of this, the plan will be sent to physics for review and any edits that they request will be made. And then after that, it's sent to the physician for their review and any edits that they request will be made. And then finally, you have a treatable plan. Before we move on to the summary, I just wanted to share this quick visualization of the differences in VMAT plans and proton plans. This is a past comparison case that I did. The VMAT plan you can see is much more conformal in comparison and more homogeneous. However, the proton plan just spares so much more normal tissue. All right, so you've made it to the end of my presentation. Thank you so much for hanging in there with me. So we'll just go through a quick overview and then we'll head straight into the Q&A. Every step of the planning process requires evaluation. It's really here that you'll see all the differences between the patients that makes it difficult to employ the same exact method. So The importing and pre-plan review needs to address possible issues prior to the planning. Contouring and plan setup steps need to address uncertainties. And planning and optimization needs to address robustness of both the targets and OARs. An important takeaway for proton planning is that it uniquely needs good and constant communication between the physician, dosimetry team, physics team, and the therapy team in order to make sure the plans and treatment are optimal, treatable, and safe. I'd like to thank the workshop organizers for inviting me to give this presentation. I'd also like to thank Dr. Sahu and Kao for taking the time to review my presentation and give their feedback. And lastly, I'd like to thank Tyler Williamson at the Proton Therapy Center for helping me figure out the outline and some of the content in it. And especially thank you to you for sitting through it with me. And please let me know if you have any questions. But if you prefer to ask them later, as in not during the Q&A, please email me anytime at cchung2@mdanderson.org. Thank you.
All right, so Christine, I believe you're here with us. If you could turn your camera. Yeah, hi. Well, first, I'm so sorry. The video was a bit bluffy, but do not worry, we will edit and share it with the participants so you don't have to record yourself again. Now we have a question from Carol Lang. You can go ahead.
Thank you very much. Very interesting talk. Appreciate that. There seem to be a lot of steps and perhaps different metrics that are being applied on the way. I'm curious about sort of a practical question. Suppose that there are two teams designing a treatment and working independently. To what extent they would come to the same conclusion?
Good question. Probably not that close. I mean, there are a lot of limitations when it comes to proton planning as far as like beam angles, which does define most of the parameters of a proton plan. So in that regard, those might be a little bit similar. And then, but even within the Proton Therapy Center at MD Anderson, everybody, like if I just picked a different person's plan and reviewed it, I would have trouble following some of the steps that they took just because it would be so different from what I would do, very likely. Does that answer your question?
Well, it does, but what are the implications?
The implications? Oh, that's, I guess, some of the importances of peer review. So we do that at the Proton Therapy Center. A lot of the times we'll ask our coworkers how a plan looks. Does it look reasonable? What would they do differently? That's one thing. And the other thing is the physicists and the physicians are going to be a little bit more consistent possibly in their review. And so it is just like a good teamwork between all of us to make sure that there is some consistency. So I guess the end result is similar, but the way to get there may be different, if that makes sense.
Thank you.
Thanks. Any other questions? Go ahead.
Christine, thank you so much for your presentation. For me, it was really, really useful because I don't have any idea how to plan a treatment. I don't have any clinical experience. So for me, it was really a learning, a lecture that allowed me to learn a lot. Could you explain a little bit better what is the difference between considering the uncertainty in the CTV and the concept of the planning target volume in IMRT? Because I think that the concept of planning target volume in IMRT is very easy to understand. What is the difference between PTV and tackling the CTV uncertainty?
Okay, so typically we do plan to a CTV depending on the site. And then we put the robust objectives on that, which is technically what a planning CTV is. And then usually we evaluate the planning target and see if it's fully covered. But many times, depending on the site, we'll mostly be working on robustly optimizing the CTV. And if the PTV is not getting enough coverage, we'll throw that on too, but not make it robust.
Okay, we have another question incoming. You can join us, Rishabh. Hope I pronounced that properly.
Thanks. Good morning, Christine. I have a question regarding the uncertainty. I mean, if there is any uncertainty caused by lipodol in patients post transarterial chemoembolization in patients of hepatocellular carcinoma, where there's a lot of high contrast lipidol inside the tumor. Does that cause any range uncertainty or any issues in planning or the robustness of a proton plan? And second, how do we account for the change in breathing pattern of liver, let's say we want to treat liver with proton, the change in breathing pattern and the beam entry through the bones and through the intercostal spaces, that could also change when it's going inside the tumor. So how do we account for that uncertainty in the plan?
It did sound like two different part questions, right? I couldn't fully understand what the first question was. If you could repeat that.
Yeah. So lipodol is a high HU contrast agent which stays inside the tumor for in patients of hepatocellular carcinoma. And if we had to treat them with proton therapy, what uncertainty would the presence of lipodol inside the tumor cause? And does it create any range uncertainty in a proton plan? Like, because you were mentioning about really high density metal objects, its HU is not as high as metal, but it ranges around 300 to 400. And if that is present inside the tumor, does it cause any range uncertainty?
I see. I don't believe I've come across this type of case, but it would typically be a conversation with physics and the dosimetrist, and trying to figure out ways to mitigate uncertainties if there are any. One good way to test if there are any to begin with is running a quick and dirty plan, basically, and then evaluating the uncertainties that are calculated by the treatment planning system. And so if those bands are still kind of tight based off of just that quick plan, then there's likely not that many uncertainties that you have to account for separately outside of a regular plan, if that makes sense.
And to the second part regarding the motion of the, let's say, the liver or the pancreas or the lung, and how treatment in free breathing would cause a change in dosimetry or uncertainties if the bone and the air interface keeps changing, every second. How do we account for that in proton plan?
Yeah. We typically, for liver especially, we try to do breath hold patients. We have not actually, to my knowledge, done IMPT for liver right now, just because of the limitations on the imaging that we have at PTC1. And the new center will be able to get better imaging on them, like cone beam, and that way they'll be able to be treated with IMPT. But currently, we're mostly treating them with the passive scatter scan plans. But we do treat them with breath holds, and we monitor that to make sure it's roughly the same. And we do very frequent verification plans to make sure that roughly in real-time treatment, it's being treated the way that we want it to be. We do use larger margins for thoracic cases, so like 5 millimeters for the PTV. And the same thing, we do a lot of verification plans on those.
Okay, fine. Thank you.
Mm-hmm.
Okay, there's another question. Carol, you can go ahead.
So as you are designing and adjusting your treatment plan, maybe between fractions, do you have any, what's missing in your portfolio of information that you would like to have, but currently do not have, that would help you adjust the plan? So, there's clearly some set of information because that's what technology provides. But what if you wanted to do something truly exceptionally better targeting? What would you like to have in terms of feedback from the past treatment?
I see. I guess usually for you're talking about like adaptive plans, like verifications that we do in between.
Something like that, right, right.
Okay, yeah, it's typically not necessarily something that was missing initially. It's more of just changes as the treatment goes on. A lot of cases, you know, the tumor shrinks or the patient loses weight. Like for head and neck cases, a lot of them, when their initial stim setup, their shoulders are up real high because they're real nervous. And then over time, their shoulders kind of drop. And that completely changes all of this anatomy here. And so a lot of times, like up here will look fine, but down here, the dose is all broken up. So it's really just the patient is just continually changing as time goes on. So as Dr. Gunn was talking about, daily verifications would be great, real-time treatment.
Okay, any other questions? Go ahead.
I saw that you choose the angles that you use really by hand. So you try different directions, you see what is happening through those directions, and you talk with the physician. And so it's really a very well thought choice. Do you think it would be possible to make this choice an automatic choice, as it is already more or less possible for IMRT? Or do you think that it's so complicated, so many things that have to be taken into account that it's not possible and has to be done in this way?
I think currently, again, so I guess it's kind of hard because MD Anderson's one of the first proton treatment centers, so our technology is a little bit behind, I guess, in a way. And so like our spot sizes are bigger. I think in Ray Station, you don't need the planning targets as much to be cropped away from metal. So things like that might be able to be more automated as time goes on within maybe a couple years, where you don't need like all of this like there's so much manual contouring and manual moving things around. Like beam angles, sometimes even 2 degrees makes a huge difference. And so one of the things that I do is if I'm struggling on finding beam angles, I just pop them on like every 5 degrees, and then I'll just edit, do quick plans, and then compare them, and then I'll pick the best beam from each of those and then combine them into a good plan. But that itself takes an entire day to do. So it is more cumbersome, but I think within the next few years, it should be able to be more automated, I think. And I believe someone at MD Anderson is working on arc treatment for protons, which also would be much better.
Do you think it would be much better? What do you think are going to be the advantages of having an arc? Will we not have extra problems with uncertainty, for instance?
I believe the concept behind that is that even if there are more uncertainties, they would kind of be fuzzy. And so it would be just kind of blurred all together so that it would, I guess, yeah, that'll be a smoother plan rather than like real just like pockets of uncertainties, because the dose will be spread out more.
Okay, thank you so much. I was wondering if there's any other question around. Okay, we will perhaps move on.